kia koutou katoa, nau mai haere mai koutou katoa. Ki tēnei o ngā kaupapa te rānei e pāna te ngā rongo Māori, ngā rongo take o tō tātou whenua me haina hoki. Tuatahi me waiata tātou I te tātou me te aroha, te whakapono, me te rangi, I e tātou e. Kia ora, kia inui tātou, let us pray. E te kaihanga e te wāhi ngaro, e mihi ana mo te hā o tō koutou oranga. Kia kotahi ai o mātou whakaro I runga I te tū wātea. Kia ua I hoki tātou ki te tika me te pono I runga I tau ingoa tapu hauni e, hui e, tā iki e. Kia ora everyone. Kia ora, and once again, me mihi atu hau kia koutou katoa e mātaki mai ana to all of those, doesn't matter where you are, across the world and that, looking in on via virtual. Tēnei te mihi atu kia koutou katoa piki mai, kake mai, haere mai. Haere mai ki tēnei o ngā huihinga tuarua e pāna ki ngā rongoa take o tō tātou whenua o Aotearoa o te whenua o Āhia hoki. Welcome to each and every one of you, the second hui to do with the international collaboration with Asian countries and talking about our original medicines of both of China and of New Zealand as well. Hoi noko ina nahi ko rongona mātou e tahi e kōrerana, tēnei rā, ke kona noki we tahi o koutou e kōrero hi ana e pāna ki tēnei kaupapa. Yesterday we heard some beautiful kōrero coming to do with our topic over these last couple of days, and today I dare say it'll be no different. We'll get some beautiful kōrero today. Hoi no koreo we toia ke hangaro wāku nei mehi. I won't drag on. I'm just so happy that I'm able to get my picture on there today. Li Feng, I tried hard last night to come in and close down, but I couldn't get a picture of myself. But that doesn't matter. Ki tēnā hau mutu pai tō koutou huihinga I ngā pō nā ngā krakia o Aotearoa ma whanaunga o te tātou rangatira Burkhardt. And he closed off last night in a lovely way. So with that, me mihi atu ki ngā mea ko wehe atu I a tātou. To those of our friends and families that have departed this world, if it's just recently or last month or whenever, e mautona na mātou te pauritanga, we still grieve for them, and we say all together through them, haere koutou, haere koutou, haere koutou. Moi mai koutou I roti ngari ngā te whai o tō tātou ariki, e moi, e moi, e moi. And with that, apiti hono tātou, hono koutou kia koutou, ka hoki mai ka tātou te umora, tātou kia tātou. To all of you watching in once again, tēnā koutou, this is my lot for now, and you might, if I'm lucky or if you're fortunate, I might be able to hook in again at around about 4:30 or whatever, 4 o'clock anyway, Li Feng, and close it down. So with that, good luck. Let God's blessing to each and every one of you. And if I don't happen to close us down tonight, I just wish you all the very best. Stay safe, and God's blessings on each and every one of you. Kia ora tātou.
Kia ora.
Kia ora.
Thanks very much, Komatua. Thank you. Thanks very much. So can I just leave the podium to Councillor Board Member Paul Young? So please, Paul.
Good morning and good afternoon. 大家好.
Kia ora.
Thank you, Manefanoa and Mr. First Toya, bring such lovely, wonderful karakia for the beginning. Thank you all for participating in the second Health Forum on the international collaboration with Asian country. My name is Paul Yang, Auckland Councillor and the County Manukau DHB board member. We all heard the great achievement on the first day of this Health Forum forum yesterday. Therefore, really looking forward to have another successful result from today. We are going to have presentations with a couple of topics and following by panel discussion. The first topic today is overall of Asian health achievement and the area for improvement. And the first topic presenter, Professor Rossini Miss John and Dr. Li-Feng Zhou. Professor Billy Zhang is an associate professor in epidemiology and the co-director of the Center for Asian and Ethnic Minority Health Research and Evaluation at the University of Auckland. She has keen interest in inequality and inequalities and challenging the health and well-being of ethnic minority communities, and particularly interested in the research on environmental determinant of health and disease. As a member of University of Auckland's Adolescents Health Research Group, she has been involved in the National Secondary School Surveys. She currently leads a Health Research Council fund research project, which aiming to explore the impact of this discrimination on the mental and the emotional well-being of intersection ethnic minority youth. And we have another presenter together, Dr. Li-Feng Zhou, Chief Advisor for Asian International Collaboration, Waitemata DHB. Dr. Zhou works at the CEO office for leading, developing, and implementing Asian international collaboration strategy of Waitemata DHB. Dr. Zhou also works part-time as Planning, Funding, and Outcomes Unit, Waitemata and the Auckland DHB boards, as the Senior Epidemiologist. Dr. Zhou does research in health needs assessment, social and pharmacoepidemiology, burn and disease primary care service, access by migrants and the health inequality. Dr. Zhou received his PhD at the Fudan University in Shanghai and his second master at University of Otago. He is the former deputy president of the PHANZ and the chair of Asian Caucus of the Public Health Association of New Zealand. Dr. Zhou also published more than 7 publications. So now let's welcome two presenters for our first topic.
Kia ora, Paul, thank you. Li-Feng, do I go first? Kia ora tātou katoa. So I will reflect on some findings of a stock take that we did on Asian health research in New Zealand, and this is based on peer-reviewed publications in over a decade from 2010 onwards that reflected findings on Asian and ethnic minorities and their health and we will explore this in terms of the current status of Asian health, as well as in terms of achievements and areas for improvement. So the study was conducted by the Center for Asian and Ethnic Minority Health Research and Evaluation, which is abbreviated as CARE, and was conducted by two colleagues of mine as well, Annie Chiang and Rachel Simon Kumar. We looked at peer-reviewed publications in the 10 years from 2010 to 2019. The study is published in the New Zealand Medical Journal, and overall, we were able to only identify 115 peer-reviewed publications on Asian health in that 10-year period. So the evidence base for research in Asian health is quite weak here in New Zealand. But if we unpack the focus of those papers, most of those papers focused on Indian and Chinese population groups, and that is not unexpected because those are the two largest Asian ethnic subgroups here in New Zealand. Filipinos are the third largest Asian subgroup, but there was hardly any research publications based on that population subgroup. And as you can see, most of the research evidence that is there is focused on Asian as only one of many groups. Independent Asian only research is quite minimal and mostly seen amongst based on Chinese population group. Most of the research relates to cardiovascular disease and quantitative research methods, most of it coming from the department I come from, epidemiology and biostatistics at the University of Auckland. We have seen some qualitative research, particularly in the area of mental health and sexual health as well. But as you can see from here, it's quite limited topics or health conditions that have been focused in the research that is published over a 10-year period. And I must note that this is reflecting research publications pre-COVID as well. So the research highlights increase in cardiovascular disease, diabetes mellitus, micronutrient deficiencies amongst our South Asian population groups, and including low birth weight as well amongst our Indian population group. The research is also highlighting high levels of stroke among our Chinese population. But the key point here is that the research that is published is only considered in a few health conditions and doesn't reflect the broad range of health conditions that our Asian population experience. Looking at health determinants from a socio-structural perspective, there is literature on culture, cultural practices, and perceptions and its impact on health. There is some evidence of post-migration hardships that this population group experience, as well as shortcomings in the healthcare system from the perspective of healthcare professionals themselves. Health service access and use there's evidence to show that health service access and utilization is quite low for the Asian population. And some of the examples in the literature point to reduced GP enrollment, reduced access of accident compensation services, reduced screening and mental health services, reduced disability support, and high levels of seeking homeland medical care. So, and that would have had significant impacts because of the border closures as a result of COVID, and would therefore reflect on adverse health impacts for this population group. The reasons for access and low access and utilization of health services, the literature points to racism and discrimination, communication barriers, lack of knowledge, social isolation, socioeconomic factors, cultural beliefs, and stigma. So in summary, the evidence base on Asian health in New Zealand is weak. It is limited to very few health conditions, and that needs to be improved. The categorization of Asian and ethnic minorities is an ongoing challenge. For instance, Asians often are grouped as one aggregate group in the literature that is there, and that we know that is a problem because there are different health conditions that different subpopulation groups within that Asian umbrella experience, and therefore that is a challenge. The literature also challenges the healthy migrant effect. We are seeing high levels of cardiovascular disease, for example, reported amongst South Asian population groups, and points to the need to look beyond this healthy migrant effect that we have been focusing on for many decades now. The literature also highlights that westernized metrics are not working for our Asian population. Westernized norms and practices are creating barriers for our patients and challenging the Asian and ethnic minority workforce as well. Barriers exist throughout all stages of life, and particularly so for young people and older people, and that's what the literature is telling us. Achievements in relation to Asian health research, we are seeing an increasing momentum in research, and which we are quite encouraged. If you look at the trends, we are seeing more publications appearing. There is a growing interest among our young people, our students, to engage with Asian and ethnic minority research. We are seeing little bits of funding starting to trickle in, which is encouraging. We have a long way to go, but it is encouraging that it has started. And even within the university, we are seeing a greater interest in educating and including courses and pathways in Asian health within the curriculum as well, which would bring a good dividend in few years' time once these are established. Areas for improvement, there is a dire need to have a strategic plan in relation to Asian health research, to develop a research framework which the center is looking to develop so that it becomes a valuable resource for all researchers across the country. There needs a greater recognition and funding of AEM research, and we need to work collaboratively to achieve for our research as well as with a view to improve the health of our population. I'd like to end with just sharing with you that we are having an Asian health symposium, a national symposium in September, and these are for colleagues here in New Zealand, where we hope to come together and share our knowledge and develop collaborations and a way forward. More details about the symposium is available on that website in the link provided there, and I'm hoping that we will get to meet and talk in person and exchange ideas and thoughts. Thank you.
Thanks very much, Roshni. Thanks, that's quite comprehensive. So I will start. I'm just conscious all the time. Thank you. Okay, so so this is a very quick, basically to complement what Roshni had said. Certainly, Roshni has done a very, very good job. So, in this part, I'm basically reporting from the perspective of the PHA Asian Caucus. All right. Okay, so I think before we just look at the achievements, the areas for improvement, we need to look at Asian population basically. So this is the basic population structure in 2021. So you can see here the green pie. we got 17% nationwide Asian population. So that's 860,000. So that's many people. In years coming, we will reach 1 million. So that's the size. So if you look at the census 2018 population here, the Asian was about 700,000. But remember, this is I underestimate that that's not a true reflection of the population living here. So thinking also about the structure, the Asian population. So our Asian population is relatively younger, and you can see at the right part, that's the age structure. The left part, that's the male, and then the right part is female. So we see here certainly for both genders, male and female, a quite good proportion of young people, say, the middle age, that reflects, our situation here. So compared with the left graph, and that's a general population in 2018. So also I think, when we're thinking about Asian health needs, we need to think about their language capability, their health needs, so the birthplace actually can be something, we should be aware of, because when you see here, a good proportion of Asian population actually were born overseas. So 67%, close to 7%. Yeah. So that's related to their language capability. And then we see the population growth, between 2005 and 2040. So we see the steady increase of Asian population, the blue line. Actually, at some point, it will overtake our Maori population. So that's quite significant. And you see here, roughly, it is more than 1 million. Yeah. We also should not forget another important population group. Even though here we are talking about Asian population, we can't forget the Mila. So the Mila is Middle Eastern, Latin American, and African population. At the census 2018, there were roughly 35,000 living in the Auckland region. So that's even though it's a small proportion or small size, but that's also important population, and we can't forget them. Nationwide, there were 70,000. I think everyone here knows that there was important review of the New Zealand Health and Disability System Review, and that very important work that resulted in the current health reform. So from this review, there are some acknowledgements. So basically, by transferring the health system, we wish we can meet the complex demands of a growing population, and to address the persistent inequalities experienced by Maori and Pacific populations, and ensure great access, experience, and outcomes for those traditionally not well served, Maori, Pacific, and disabled people. Also use technology, data, and digital, and develop new and innovative ways of working. And that's actually, our collaboration work, has been focusing on. And focusing on keeping people, their whānau, their family, and their communities well and out of hospitals. And that's important because when we do the prevention work, the work in the communities, we can actually save a lot of money. We can also save their lives, and they can live well. So this is the 5 principles of the health reform on the way. So you can see here, definitely the health system will have to reinforce the integrity of Wantani principles and obligations. And all people will be able to access a comprehensive range of supports in their localities, and they can stay well. Also, everyone will have equal access to high-quality emergency and specialist care services when they need. So this is basically to remove the lottery, lottery thing. And digital services are quite important, and the digital part can be a very important enabler to make things happen. And number 5, health and care workers will be valued and well trained for the future health system, and this does apply to our Asian workforce. So, we have been talking about Asian. So who is Asian? Stats New Zealand actually adopted the idea about so that's so our concept or our definition of Asian in New Zealand is the people from Afghanistan in the west to Japan in the east, and from China in the north to Indonesia in the south. So that's our basic concept of Asian. And also, I think we have got different categories or hierarchies. In the health system, we have level 1, level 2, level 3, level 4. In many cases, the health system can only report level 1. And even for that, patient sometimes has not been reported against. So that's, there's a long way to go. We definitely need to make all these indicators available for Asian population. And then, we move on, to look at the Asian subgroups, say level 1, level 3, and level 4. Also, I think Roshni mentioned Asian people are very diverse in language, culture, health, and digital literacy, their religion or faith or settlement history and health needs. So we acknowledge very different cultural and cultural needs and health needs. So the Chinese people may have different needs from Indian or Southeast Asian or other Asian. But even say within the Chinese group, there are also subgroups. So we help people from mainland China, we help people from Hong Kong or from Taiwan or from Singapore, Malaysia or Indonesia, Cambodia. So they're all different. The health sector certainly is fully aware of the risk of using the broad Asian term in health planning, funding, and healthcare delivery. And that's something Roshni has mentioned. So the averaging effect actually could potentially mask the true health disparities between the Asian subgroups. So we all need to be aware of that. So to address that issue, we do need to get all the indicators are available at a level 2, level 3, level 4. So we have a lot of work to do. However, Asian, even at level 1, has not yet been reported in a systematic way in New Zealand. So we have to make a lot of efforts to make that happen. And I think the health reform would be a very good time window for us to do something positively. The health sector actually is not saying they are doing nothing. The health sector has been doing a lot of great work. So the 3 Auckland DHBs and Northern Regional Alliance, together with researchers or academics like Roshni and others. So we did understand Asian groups experience high level expectancy, even though it can be partially explained by the health environment effect and the overall good health status. But with disparities between Asian and MELA subgroups, there is also a lack of data, and that's I have already talked about, and lack of understanding for many Asian people, lack of understanding or awareness of the New Zealand health system, and unmet language and cultural needs in accessing healthcare services. Significant mental health and addiction issues such as anxiety and depression, and that's further exacerbated by the effect of COVID and racism. I think in early 2020, I'm sure you're aware something happened in New Zealand, and also perinatal mental health issues are important. And that there is a project I understand. Grace Yu and her team and Dr. Maggie Ma and our community providers like Tani, like the CNSC Foundation, they are working together to address that. And for oral health and lower level of screening rates, like for cervical, for breast, and for bowel. Lack of health promotion, prevention, and public health, including culturally tailored preventive lifestyle activities like smoking, lack of exercise, and physical activities. Sexual health, youth health are all important things we have to address. And we do need to adopt a partnership approach to engage segments of the populations, such as students, former refugees, and current asylum seekers, in awareness raising of health services and health education. And we do need to work together, like you guys, Asian Family Services, CNSSC Foundation, Age Concern, Asian Network. We all need to work together, and all other community organizations. So there are lots of papers published. Roshni has mentioned the work done by her and Chang for the 10 years. And the DHB, the health sectors have done a lot of analysis, health needs assessment, health plan, and the Asian Health Chartbook that's published earlier, and health needs assessment reports by Vatmana DHB, Community Medical DHB, Northern Regional Alliance, and the International Asian Benchmarking Report by Vatmana and Auckland DHBs. We do have a very important health plan for Auckland and Vatmana DHB for Asian population. So some work. The first one is done by Tani, and then we got the other important works. So we are here not with nothing. So we do have something. Oh. Sorry. I'm not quite sure if you can still see me.
Yes.
Okay, that's cool. Yeah. So and then I think we need to look at the model for Asian and ethnic populations. So here, this is a graph reflecting the Vatmana DHB model. So here we have got Asian health services led by Grace Yu, and we have got Asian international collaboration. We have got Asian health gain that's in planning and funding. And certainly, we also need to work with the community organizations. So, Vatmana DHB has been doing fantastic work over the years, because we have excellent leadership. So my question or our question is that, can we actually enhance this model and make this model not only for this DHB, but at least to this region or to other regions? So that's something important for us to think about. So the key recommendations by the Asian Caucus PHA is to acknowledge Asian and ethnic minority group as population groups in any reporting, and to include people of Asian and ethnic minority groups in the decision-making process to achieve health for all, and to provide for policy and direction on investment changes to make visible the unique health needs of the Asian and ethnic minority populations, to set up well-resourced support structure within Health New Zealand for planning, funding, commissioning, and delivery services for Asian and other ethnic population groups. So we will not have the national health strategy. That's pretty clear. And we did say something from their commentary why this would not happen. So there will be, I'm very happy to have the Maori health strategy for Pacific, for people with disability, and also women's strategy. So if there is no such a strategy, how can we move on for the Asian population? Clearly, we need to have some policy at high level, at the national level, and then there should be some plans for the regions, 4 or 5 regions nationwide, and there have to be delivery or operation services at the district level. So we all need to work very, 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 very hard. So what we can do is, one, advocacy by the PHA or other NGOs, engagement with health authorities like Ministry of Health, Health New Zealand, and Maori Health Authority, and working well with regional and district directors for Health New Zealand. Also, maybe a statement and media exposure by the PHA Asian Caucus. So our minister Andrew Little just recently said, our future health system will be nationally coordinated, regionally designed, and locally tailored to address long-standing inequity and the postcode lottery. And that's excellent. That's wonderful. So we do, wish to use this rare opportunity to reduce inequity, save for our Maori and Pacific populations. But we also want to see that the Asian and ethnic minority population health needs can be met. That's not going to be ignored. We are going to have 1 million population, okay? And not only because population size, we do have unmet needs. There are so many things we have done, and we can do a much better job. Thank you very much.
Okay. Thank you, Professor Billy Strong and Dr. Zhou, for both such a rich presentation. We're actually 8 minutes over. And our next topic, health service model for Asian and the ethnic population, the present and the future, by Ms. Grace Ru. Grace Ru has been working with the Asian and the ethnic community for the past 25 years. And he worked for the Waitemata DHB board for DHB for 70 years. She's current operation manager of Asian Health, co-chair of Asian Mental Health and Addiction Clinical Governance Group and the COVID-19 Incident Management Team, function lead for Asian population at Waitemata DHB. Grace, floor is yours. Thank you.
Thank you, Paul. I will share my screen. Can you see the screen now? Great, thank you. Thank you, Paul. Today I'm going to talk about Asian health service model for Asian and ethnic population. What is currently available, and also what is our dream or wish list for the future. I will briefly introduce about Asian health service. I think many of you know about our service, but recent years we have a dramatic changes in service delivery with the more updated services. Asian health services is a unique Asian ethnic specialized service among 20 DHBs in New Zealand, and currently sit under Waitemata DHB. And we are now, moving on to under Health New Zealand very soon, in 1 month. So we were established in 1999. So we are 23 years old. And we started with a very small team within a bunch of volunteers, because there was no such resource available. So we were highly dependent on volunteer capacity in the beginning of them, lasted almost 20 years. But now we have developed a very comprehensive services with a professional team of almost more than 260 people, 23 FTE, 42 contractors like mental health psychiatrists, psychologists, and also our ethnic cultural workers. And also we have over 200 ethnic language interpreters. And we are designed to provide a culturally and linguistically appropriate service for our population by reducing any inequalities and removing any cultural barriers to achieve better health outcomes. So this is our service structure. Under Asian Health, we have a 4 division: Asian Health Line, Asian Patient Support Service, Asian Mental Health Service, and what is interpreting service. I will explain a little more about it. So this is a unique service, and also first in our nation service. When we established 1999, maybe it was in a first ethnic or Asian agency in government sector. So I remember I joined in 2004-5. There are a lot of inquiry, not only health but also other inquiry. But now there are so many Asian-specific services available in police and Ministry of Ethnic Communities and everywhere. So we have in a better position to focusing on purely health sector. So Asian Health Line was previously eye care call center. October last year, we upgraded our call center as a national Asian Health Line. You can see a lot of number 8, right? Our especially Chinese colleague love this number. Easy to remember. 8 is lucky number. So I hope you all remember 0800 88 8830. So this is basically, we are like in a CAB, health CAB. So I have no idea whether GP, they can contact us. What is a plunket? What is a hospice? And where is my hospital appointment? And also referral, and also smoke-free, alcohol and drug service. They can go to find out where to go. At the moment, we are very busy with the COVID response and also breast screening. So I will tell you more about some data at the next slide. Asian patient support services available Chinese, Korean, Indian, Filipino, Pakistani, Japanese, Vietnamese, Indonesian, and Thai clients for the no-show and Waitake Hospital at the moment. Very comprehensive, but also strong advocacy for the hospital inpatient, and they are far now. And also during the COVID lockdown, there was no visitor policy for a long time, and our team were really happy to support their vulnerable hospital inpatient during the difficult time. And also they do have social cultural assessment, and also they advocate patients' best interests at the multidisciplinary team, and also family violence or elderly abuse, any family dynamic, we are helping in the hospital, and also 6-hour follow phone call. We wish this service available all the public hospital in New Zealand, just like a Maori Pacific cultural services in every hospital service available. So our team also provide cultural advice for the hospital clinicians. We hear, doctors, telling me, I was in no-show hospital, it was available. Why? I'm in Middlemore, why it's not available? Can you come over? Yeah, we would like to really see some positive change in the future. Asian mental health service is available for the very different cultural background client. This is service designed for the secondary mental health and addiction services who are diagnosed with schizophrenia or severe depression and bipolar, and also we are helping their far now, because there are a lot of far now engagement, care stressment available, management required. There are more clinical intervention with the psychoeducation, life skill counseling, and also well-being group for their peer support as well. So it is available not only inpatient but also outpatient, because of the most specialist mental health clients in the community to minimize any human rights issues in the unit. Our Watis interpreting service cover over 19 languages, not only Asian languages, but also most of the European and Pacific, also including New Zealand Sign Language. We are operating 24/7 days. We don't sleep. And face-to-face, telephone, and video interpreting service available, not only hospital setting, but also primary health setting. Originally, lots of many GP referrals, but during the COVID situation, we got a big number of pharmacy referrals for the interpreting, free interpreting, because of the my vaccine pass and flu and COVID vaccination available in local pharmacy, just walking. That's what people prefer. So these are some achievement last 10 years. We just have some snapshot of last 12 years. So quite big number of case load. And biggest achievement is our Asian Health Line become a national overcome from the in our DHB setting from the and now available national COVID-19 service line and breast screening from 43% to 70% in a national target. And hospital do not attendant rate was in an average 6 to 7 and also some other ethnic group 10 to 12. But if they use our what is interpreting service, only 1.5 DNA, we are really saving health dollars and for the efficiency and lesser waiting list for other general population. So this is our service broad chart. If they don't know where to go, they can contact our Asian Health Line Eye Care Call Center. If they are at the GP clinic, pre-interpreting service available. If they are in the hospital, like a public hospital, secondary care, what is interpreting, and patient support service for our DHB hospital, and also our dedicated mental health service team can help. And when they discharge from the secondary hospital services, we helping out transit. So they are not just kicked out from the services. We just make sure community NGOs can follow up. So we are working with the TANI and CNSS Age Cancer Asian Family Services for their service available in the community. Now, we have a COVID situation. What changed? During the COVID situation, technology really helped us. Without technology, we couldn't deliver the service. All our more referral to be online referral to save our time with the busy workload, and all our consumer survey done by online Zoom, Survey Monkey, and all our workshop from the face-to-face, everything was Zoom. So we had a COVID-19 seminar working with Sky Kiwi. We realized that over 8,000 people joined the Zoom webinar. Thank you, Sky Kiwi. So we realized the technology, and also we overcome the distance. Nationwidely, people joined the workshop, not only small local area. It was amazing. And our service team need to use CIR, CICS, Eclair to put our clients, patients red test outcome into the system. And also their My Vaccine Pass, travel certificate, uploading, everything done by electronically. And telehealth, it was our long-term dream, but it didn't happen before COVID. But when we start lockdown 2020, there is no option. We all go with the telehealth. We can launch video interpreting service finally. So we are very happy. Now through this beautiful systems, we now can help with the people within a red kit and food email to our community connectors, order the relevant toolkit, and also our team can order medication for the COVID patient. It can be delivered their home, which is amazing. So this is our website. And also we will upload more languages available in 12 different languages. So our Dr. Rifeng briefly showed this Asian service delivery model available in Waitemata. So we have a 2 governance group and provide Asian health and international collaboration and planning and funding team. And also we have a health action plan to get good direction. However, this is only available in Waitemata DHB area only. So this is our wish list now. What we would like to see in the future. We would love to see highly performing national, regional, and local unified Asian ethnic health services model. This is we really want to minimize any systematic, minimize all systematic inequalities. There is no policies and strategies and action plan at the moment nationwidely. So we would love to see the positive change on the Health New Zealand. And also we can hear, it is available in Waitemata, or now it is available in other area, which is, it will be really good news. And also dedicated and appropriate service delivery for Asian Mela under Health New Zealand. And also family-centered care, and also promoting community empowerment is really important. And this is in national COVID data. As you already know, booster vaccination rate was not really great. We are working hard on it. So this is Asian Health Service last 10 months data. So overall, 47,000 inquiry last purely 10 months for the COVID response. Some older people from older adults from Taupo, Gisborne, and Invercargill, because they are more isolated in that local area. This is some data which Tani and CNS is working with for perinatal mental health and well-being project, Mother Healthy Future, some snapshot. So we want this kind of mental health initiative more nationwide. At the moment, Waitemata available. So this is our values. Improved. We are dealing with the health equity and improve. We want to see improved health policy and knowledge, and also partnership. In our center, community is our core value in our every value system. Co-design with them and engagement and partnership with the local community NGO is really vital. And lastly, I just want to emphasize that we would love to see the governance leadership under the Health New Zealand governance group and interagency advice group for the Asian and ethnic communities in national and regional level, and dedicated Asian ethnic health services for the better health outcome knowledge and valuing. In our DHB, 34% of our health workers are Asians. So acknowledgement and valuing them and making relevant strategy for our valuable workforce is really important. And we have Dr. Roshini here, and we have a Grace Wong and AUT. They do need well-resourced, and they are always in a lack of resource or no funding. So we would love to see well-resourced research for the evidence-based practice and future service delivery and quality standard and cultural competency training, and also cultural safety advocacy is really vital in the future service delivery model. Thank you. This is my talk today. Thank you.
Thank you. Thank you, Grace, for such wonderful presentation. And your Asia Health Service by you and your team is amazing and outstanding. Thank you. And our next section for Voice of Community Organization, which is with the three presenters from the three different groups. The first presenter, Miss Gloria Gao, and from CNSST Foundation. Gloria is Chief Operation Manager of CNSST Foundation. She immigrated to New Zealand in year 2006, being committed to migrant and ethnic community development work for last 15 years. She holds master's degree and the candidate for Doctor of the Social Work, also the committee member of COGS, the board member of Ecg Monitoring Primary School, and advisor of Ecg Auckland. So let's welcome Gloria. The floor is yours. Thank you.
Thank you very much, Paul. Kia ora, hello, ni hao, everyone. I'd like to share my screen. Thank you. Yeah. Can you all see my screen, please? Great, awesome. Yeah. Okay, above all, I'd like to introduce our organization, CNSST Foundation, formerly known as Chinese Settler Services Trust. We are a registered charitable trust since 1998. And we provide migrant-focused social services, education, and social housing. And also, we are the high-trust accredited provider for different government organizations. In terms of the beginning of our organization, it's quite interesting and legendary. As most of our network, we all know, we started from 1997 from our founder and executive director, Jenny Wang's home garage. And now we have developed our organization as one of the largest Asian NGOs in New Zealand, with one head office and 6 branches throughout the Auckland region. This is our lovely team. So we have over 200 workers working with our community, including our staff, our board, our contractors, and our volunteers. With everybody's commitment and efforts, we helping providing professional and culturally and linguistically appropriate service to our migrant community. And the service categories I have briefly introduced, including education, social services, social housing, and also we have some domestic and international engagement projects. In terms of the clientele, annually we serve about over 15,000 people from 20 plus different ethnic groups across the Auckland region. And in terms of the health and the well-being services, we have kind of summarized in 4 different categories, including the prioritized work, the COVID welfare support at the moment, as well as the public health promotion, what we do including the information hub, health workshops, referral services, and also we do the awareness and access support. And for instance, the COVID-related translation services, vaccination-related information, and the video production of NZ Health and Disability System introduction, as well as those kind of community-based workshops. For maternal and children's health, we have the Healthy Baby, Healthy Future program, as well as positive parenting and follow-up support for the behavioral change. And mental health is also one of our key prioritized services for our community, including prevention and intervention support, like the Healthy Mothers, Healthy Future program with Asian Health Service support, and in partnership with Tani as well. And also we have the TICU-related recovery therapy service, social work and counseling services in pair with mental health professionals, anger management courses, children's counseling, final center wraparound support, and etc. So today I like to merely present the service model we do in terms of the Unite Against COVID-19 CSSD service response system. From the last resurgence and the lockdown in August 2021, CSSD have directly supported 7,396 plus migrant community members in the provision of online support, as well as the contactless delivery for individuals, funnel, business, and other groups. So we kind of use this kind of model, starting from the connection by improving our community's awareness and accessibility to the available services through the weekly government information updates, online services, as well as the multiple language support to ensure the timely and culturally appropriate services. So with those kind of awareness, we do the response service. That's to support the people in isolation, home-based isolation, or in the related isolation center. So CSSD was funded by NRHCC and now by MSD to do this kind of timely support as the community connector for our community. What we do, we have the source of referral from government, as well as from the self-referral from our communities and the community network organization referrals. What we do is for people in isolation, we provide food parcels, non-food essential support like PPEs, red test papers, vaccination bookings, emotional support in their most difficult time, financial assistance for those people in financial difficulties under the impact of COVID-19, crisis interventions like some of the cases people are suffering from mental health, suicide. We work with crisis team to deal with those kind of intensive cases. and especially for some overstayers who have no access to any government support, and they're reluctant to do those kind of approach. But what they can do is to approach the organization like us. I think during this COVID-related situation, this kind of community-based, mutually supportive and trustworthy relationship, and also the timely support for those overstayers with no other access to this kind of support services are extremely important. Like we have them to arrange for the related essential support, financial assistance, vaccination bookings, etc., to empower them to go through the difficult time. On top of the timely short-term intervention, we also have the long-term recovery approach in place. So as you can see at the left side of this triangle, we think it's very important to help people to empower them to be adapted to a new normal with the influence of COVID-19 by having them in the center of the services. And based on their needs, we provide a recovery service, including employment, education, social housing, immigration or visa-related support, and settlement support, and etc. So, so far, the service model has been really well received by our community, and that meets the immediate need, and also to improve the well-being and health of our community. Next is regarding the mental health and well-being service. I'm giving an overview. Among the 793 referrals we received from police or health sectors, about 27% are mental health related services. And on top of that, we have 46 children-focused counseling interventions as well. So as you can tell, it's quite a high demand of the mental health and well-being service from our migrant community. And on top of the service delivery, we also do the constant study and development on the ethnic service models. This is one of the examples we have developed by our team, empowered based on the mindfulness and non-violence communication knowledge base. What we do is called I Care, We Love. So starting from the self-emotional awareness, mindfulness, and emotional management, to connect with the positive communication approach with your family members. So this has been used as the preventative workshop to improve the mental well-being and the communication under the impact of COVID-19. In the meantime, it's also used as an approach to deal with the family conflicts. So it's been really widely used and well received with the culturally appropriateness. So last but not least, I'd like to talk about the identified needs and expectations based on our frontline work experience and from our community voices. Firstly, we have been witnessing the limited use of the health and well-being services because of the limited understanding, limited resources, or accessibility. So we are very happy and very grateful to say that the health system reform at the moment is to improving the consistency and equity among all different ethnic groups across the national areas. So we think it's very necessary under the current reform, and it is the right time to have the ethnic health and well-being strategy focusing on the ethnic community need in the health and well-being services, so that with the guideline of the strategy, we are going to be having the equitable planning, resources allocation, as well as the service delivery. So secondly, as the service provider, we like to have the equitable access, funding access to this kind of health-related resources. I have shared a lot of services. I like to say, in terms of the related resources, regretfully, CNSST don't have any direct MOH contracts. We only have a few small projects funded by DHB at the moment, but we are very committed to do this kind of wraparound support for our community. Last but not least, I think what we are aware of is that for the current health system, the government have been committed to provide cloud services by building the current existing providers with the ethnic workers and the cultural training. But what we'd like to say, actually, it would be more effective and culturally appropriate in alignment with the increasing population of the ethnic population and the aging population to have more ethnic providers, because ethnic workers don't equal to ethnic providers. So as the research also shows about the health-related determinants and also about the complex needs of our community. We like to say health is quite and well-being is quite complex needs, and it needs a wraparound service and not just provided by a one worker or one team, but it needs to have an organization, provider, and a community network as a base. For example, health related to the employment or related to the housing related needs that would eventually contribute to the achievement of the health and the well-being of one person and their family. So with more support from the ethnic providers with the community as the base, it's going to achieve a more sustainable health outcome for them. Passion, vision, action, we make the road by working. Okay, so we are committed to support our community, and we hope that we could do more for our community. Thank you very much for listening. Thank you.
Thank you, Gloria. Wonderful presentation, and thank you, CNAC's team, the great work in the community. Our next presenter, Mr. Vishal Rossi, and director. He's the director of the Asia Network, and also the White Ribbon Ambassador. Last 20 years, he has been actively involved in advocating for advancement of the well-being of the Asian New Zealanders and an ongoing contributor to the health and the well-being sector while addressing determinants of the health at various levels. If anyone have a question for the next section, the panel can leave your question on the Q&A. Now, Vishal, the floor is yours. Thank you.
Thank you, Paul. A sincere greetings to all of you from Asian Network, and thank you, Paul, once again for beautiful introduction, and thanks to Aotearoa, if he's still here. Tēnā koutou katoa, ni hao, namaste, assalamu alaikum, ahanseo. A warm Pacific greetings to all of you. I know we are approaching to winters, but still our greetings are always warm enough. So I'm just trying to share my screen now because thanks to Gloria, first of all, because Gloria has covered most of the aspects which we had in our presentation as well. And also the community connector services, which CNSST, Asian Network, and Asian Family Services, 3 of the speakers have as well. So I won't repeat what has already been covered from Gloria on the community connector service. So just trying to share. Oh, can you see the screen now?
Not yet.
Not yet. Oops.
Yes, we can.
Oh, that's not the page. Sorry. Okay, let me try again. Oh yeah. Right. Can you see it now, everyone? Can you see it now?
Yes, clearly.
Yeah, okay, wonderful. Thank you. So we are also known as Thani in the community. Thani was established in year 2002, almost 20 years now in the community. And from the day one, we have been fortunate enough to be supported by the Ministry of Health. We were really very marginal when we started, but due to the greater needs of the community and the continuous advocacy, we managed to grow our services in the community. Primarily, we work under the public health spectrum and social services just recently. Thani contributes empowering the community to respond to the emerging health and well-being needs and acts as a bridge between the mainstream service providers and health service providers. So before we get on to the learnings from the COVID and the digital inclusion aspect where we have to base our presentation for today, but I would like to mention inequities that are currently existing in our Asian health system here in New Zealand. There are lots of health disparities. They are very much visible when it comes to health for Asian New Zealanders. So if you click on this link, you will be you will be able to access the recent Asian Public Health Report in Aotearoa that was published just recently, late last year. So in that report, probably racial discrimination, mental health, family violence are amongst other key concerns for the Asian community in New Zealand. And due to COVID in last 2 years, we have seen a greater increase in these issues within our communities in New Zealand. And relative to New Zealand European ethnic groups, the Asian group as a whole has a low level of access to health services and healthcare utilization. And that is the point where Asian Network's expertise comes into play to enable the communities to have a better access to these services. And possible contributors to these disparities include stigmatization, language and cultural barriers and behaviors, and understanding of New Zealand health system as its own. As our previous speakers have already mentioned, that Asian is a very broad group and everyone comes from different countries in the Asian continent. Each country has their own health systems. And as a result, we all come here with a different mindset of health services in New Zealand. This is the Ecg Charter model which we base our services on, and where Asian Network fits into this particular model is strengthening community action, enabling, mediate and advocate, create supportive environments, and reorient health services. So we do all of these center part and the top part over there, and also contribute to build healthy public policy by contributing to the various government submissions time to time and continuously advocating for Asian health and well-being. These are a few of our activities and other delivery model. I won't get into too much details because I'm just cautious of the time. We're already running behind, but I will leave the presentation with the organizers to share it further with you. This is, we live and breathe the community, the heart of the community. So health promotion programs based on the principles of engagement and empowerment offer the real benefits. This is what we believe in, and this is what we deliver. So moving on to the digital inclusion part, which was the key highlight for today's talk, that how digital inclusion or digitalization of our services have played a great role during last 2 years with the communities. Of course, COVID has brought us a great challenges, and especially the challenges to address language and cultural needs digitally, and to convert all existing service delivery models and programs to digital platforms. That was a big challenge as a provider. Extremely limited resources. Again, as Gloria mentioned, there have been, every NGO is pressed for resources in New Zealand, especially when it comes to Asians. So very high community expectations at the same time, because community was in a great need for some support, but there were not digital solutions right away available during that time. But I think over the period, all the providers have developed those capacities and capabilities within their teams. And also the community readiness and adaptability for online solutions was also not there. For example, as simple as you're consulting your GP over the phone. That was a very new concept. Again, how can we consult our GP over the phone? But now, after 2 years of COVID, it has become a normal thing for everyone to do. So which means there's a lot of learnings this COVID has also brought to our fora. And of course, the increased isolation was another big challenge, how we can get or reduce the isolation part while everyone is in lockdowns and with the digital solutions. So again, as I mentioned, there are lots of successes this COVID has taught us. COVID not only brought the challenges, but the opportunities at the same time. What Grace mentioned, the uptake of the community, the outreach of our providers have increased, not from the locality to region to nationwide, and national to, look at this example today, to international as well. We are sitting in our places, but we are contributing and learning from the world. So online program delivery started and well received. Community outreach increased dramatically. Online mindfulness and yoga sessions were super hit. E-learning modules and several new online learning platforms were developed, which is again building the organizational capacity and capability. An empowered community to receive and accept online solution is the absence of face-to-face. So what I mean to say in the last bullet point is, it's all good to have digital solutions to address our health and well-being issues, but digital solutions should not be compromised. Like the face-to-face solutions should not be compromised at the same time. So digital solutions should not replace face-to-face interactions. So it is in addition to what we used to do. This is some of the glimpses of our digital inclusion, all the digitally delivered programs, some glimpses, and also this is my favorite quote: only when all contribute to their firewood can build up a strong fire. So we all have a role to play. So we all have to work together to address Asian health in New Zealand. And these are few of our collaboration partners. And we would like to acknowledge the organizers for today's forum, and also Ministry of Health, MSD, our board members, Department of Internal Affairs, all the district health boards and partner organizations. Kia ora koutou, tēnā koutou, tēnā koutou katoa. That's very quick and fast, but I think I'm open to questions. Kia ora.
Yep. Kia ora. Thank you very much, Vishwa. That's wonderful presentation. Thank you, your work and the Asian Network. Thank you very much. As you say, we need to working together.
Yeah.
Our final and the next presenter, Mr. Ivan Yo from the Asian Family Service. Ivan, born in Singapore and raised in Malaysia, and come to New Zealand as an international student in 2001. In the past 18 years, he has been involved in many projects. Ivan believes in raising awareness of the mental health and the well-being for the migrant community, and hopes to empower individuals to flourish in New Zealand society. Floor is yours, Ivan.
Thank you, Ko Ivan Yotakiwa. So my name is Ivan. I will try my best to stay with the 5 minutes. I know we all are over the time. So I'm just going to do a deep dive into some of the research. You can see my screen, all right? Yep, awesome, thank you. So I just want to point out some of the research numbers that we have done. We have looked at the New Zealand Asian Wellbeing Mental Health in 2021. Interestingly, when asked a couple of questions about self-rated satisfactions of life and worthiness, Asians seems to be very happy with their life. However, when we use a Center for Epidemiological Study of Depression scale, it actually tells a very different story. It's about over 40% of individuals, especially more prominent among young people, who actually have shown symptoms of depressions. One of the beliefs is that when it comes to mental health issues, Asians mostly experience somatic symptoms instead of psychological symptoms. Another challenge that it has is that most of the Asians probably a lack of mental health literacy. So to understand what mental health is, probably we are still about 10 to 20 years behind. That is my personal belief in New Zealand, because of lacking of culturally and linguistically appropriate resources and informations. And that is the same when we conducted another research looking at the perinatal mental health outcome for Asian women. Again, this research show a significant, like 14 out of 17 of Asians show symptoms of depressions when Castle Psychological Distress Scale was instrumented to assess individual. However, those symptoms did not pick up by the GP, by the midwife, or by those who are as a health professional from mainstream. And this actually highlights the need to have a culturally competent workforce amongst the New Zealand health systems. But what I really want to emphasize is when we look at 2020 New Zealand Asian mental health and well-being, we found a very different patterns of seeking wellness. When someone is not feeling well or needs some help, majority of them will seek help from friends. And it's only 28% will look for help from doctors, as compared to mainstream, where 69% actually will look for a doctor for health or other health professional. As Asian Family Services are actually funded by the Ministry of Health for gambling levies, I also want to highlight that there's a lot of significant number of Asians who experience gambling harm as well. As you can see, is close to over 50% actually experience who have gambled in the past 12 months, but about 13.8 actually have problem gambling issues. But what really has been interesting is usually they only come to us when they have exhausted all the resources. But what is more importantly is the gambling harm as health issues is not well understood by the Asian communities. The word addictions in English seems to be only associated with substance abuse instead of behavioral addictions. So there is something that as a collective we need to raise to change the perceptions about being understood what's mental health, what problem gambling is about. As many of you has actually highlighted some of the challenges, but I really want to emphasize that for workforce development, for culturally and linguistically appropriateness, we really need to focus on recruitment and retentions, but also increase the competency for mainstream to understand how to work with Asians and ethnic minority. And that is something that is not being done, and it needs urgently. I would urgently urge the government to invest on mental health for Asian and ethnic minority. Compared to other ethnic like services, we probably not even have 1% of the total mental health spending compared to the rest of the population. That is a huge inequality issues. Asian Family Services actually started in 1998, so we have other services, including Asian Helpline, where people can call us for brief psychological interventions. But like many of you have mentioned, we also have parenting program. But in last year, we launched interpreter services. Sorry, I'm trying to rush through it. So the interpreting services is use a digital platform where people can book and also match with language support that they need. But I want to emphasize this. This is created for a primary health sector, but not secondary. What Grace Waters is secondary health services. Our one is primary services. So we're trying to meet that gap. So I don't want to further taking much of your time. Go to our website. All information are there. Thank you so much.
Okay, thank you, Ivan, and thank you for Asian Family Service. Always do the good job for our community. And I think thank you for all three presenters in this section from the three different organizations. And we move to the next one, panel discussion. But may I ask Dr. Zhou? We actually timing for panel discussion finished by 2:25, but now it's 2:28. So shall we?
Yeah. Thanks, Paul. Thank you. Certainly, we got a wonderful speakers. Everyone, would like to share their thinking, their insights, and that's great. I guess maybe we just have 5 minutes, for panel discussion. I think, and then we just ask Professor Wang to wait for 5 minutes. So thank you, Professor Wang. So I know here we got Romeo from the Ministry of Health.
Yes,
he has not yet spoken. So I guess maybe we just have Romeo to have a few words with us. Thank you, Romeo.
Okay, maybe Romeo, before starting, let me introduce Romeo and principal advisor. Yeah, principal advisor and working in the Ministry of Health as the principal advisor. And he will join our panel discussion. Floor is yours, Romeo.
Romeo, yeah.
Thank you. Kia ora, Paul. Thank you so much, and thank you, Lifeng, as well. Yeah, good to be here. And yeah, it was a really great presentation first. I really like to thank you for bringing all the information here. Thank you to Lifeng. Thank you to Grace, Gloria, Vishal, and Kelly. Yeah, really appreciate it. And mostly today, most of the things, what are the barriers, what are the issues, what are the concerns, and what are the impacts, those type of things are mostly covered by most of you. Now I think we need to look into how we can implement into these things into the ministry's strategies and policies. That's what we need to focus on now, because we got the information now. We might get other further information, but we will be working on that. But in addition to that, our next step should be how we can go in there, fit in there in the ministry's policy. What will be the framework for ASEAN communities and Mela and other ethnic communities as well. So yeah, this is my point to be roll out in the amongst the panel. So if you have any points or notes, please share with us.
Thank you very much. Yeah. I think probably I can pass the floor to Dr. Zhou, but the first time as a facilitator, I'm quite enjoying it because I'm not from your in the background. But I would like to say, actually, my feeling the government did not aware of the series, did not put too much attention. We're working very hard, but probably we need to how to engagement. Can I using I think one thing very important for our Asia in New Zealand, people need to go out for voting. The voting, the people will listen. If we only talking in each industry or different field, if we not go out for voting, the people have to listen. So sorry, that's another on this discussion for this form. So the floor I pass back to Dr. Zhou. Thank you very much.
Thanks very much, Paul. I think it's great facilitation, even though we have run over time, but I really enjoyed as you, and thank you for your wonderful job. Thanks, Paul. Yeah. So we just move on to our next session. So we invite Professor Qin Wang to facilitate the two speakers. Thank you, Professor Wang.
Hello, everybody. Can you hear me? Okay. Thanks for Dr. Li Fengzhou. My name is Simon. I'm working in Shandong University, and I am very interested in expanding our research on social determinants of health outcomes and health service using with big health data. Therefore, I'm very appreciated to be part of the seminar because I suppose it is a good opportunity to promote health outcomes and patient experience by using new technologies in this session. And I'm very honored to present the next two speakers. However, I have to say I'm very sorry that they cannot communicate with us directly because they have important meetings to join. So they recorded their presentation, and I believe all the two speakers are very welcome any kind of communications. So if you have any problems, please feel free to contact the two speakers. So here is our first speaker. The first speaker is Professor Zheng Qiangkou. He is responsible for the Department for Infection Disease Control and Prevention in Shandong CDC. He is going to talk about our fight against the COVID-19 in Shandong Province, China. He is very experienced with the epidemic prevention and control and has been rewarded for the COVID-19 prevention and control. So here is his presentation, the prevention and control of COVID-19 in Shandong Province. Thank you. Dr. Li Fengzhou, would you please play the video for us?
Thank you. Yeah, thank you. Just a moment, please. Yeah.
Good afternoon, ladies and gentlemen. At first, I'm very sorry to say because this time this meeting conflicts with my another important one of mine. I can only record it for you. My name is Jack Ku. Chinese name is Kou Zhengqiang, come from Shandong CDC. I have engaged in the prevention and control of infectious disease for 18 years. And glad to have this opportunity to share my experience in prevention and control with you. I'm going to spend about 30 minutes talking to you about the following three things. First, I will now give a brief overview of Shandong Province. In the second part, I will introduce the COVID-19 epidemic in Shandong Province in the past 3 years. In the third sector, I will focus on the effective measures and experience of Shandong Province in deal with the epidemic COVID-19. This slide shows the Shandong. Shandong Province is located in the east coast of China, downstream of the Yellow River. The territory includes the Peninsula and inland two parts. Shandong Peninsula protrudes in the Bohai Sea and the Yellow Sea. The Beijing to Shanghai, the high railway is or Chinese main rail artery passed through the Shandong province and Japan and South Korea across the sea. Frequent trade exchanges and close personal exchanges, and is the hometown of Confucius. His hometown is Qufu, one of the county of Jining City. This slide shows the province has a land area of 155,800 square kilometers. The 12th in China. The population is 102 million. It's the second in China. Shandong province is the third largest economic province in China, with a GDP about 80.3 trillion yuan in 2021 year. Like the third in China. Shandong province jurisdiction includes 16 cities, 136 counties or districts, about 1,822 townships or the streets. In the second part, I briefly introduce the overview of COVID-19 in Shandong province. There were 912 native cases and 190 imported cases in 2020 year. The peak incidence in this year in the 2020 was mainly concentrated in February, affecting 50 cities in the province. Only one, Dongying city, have no cases reported. The epidemic was effectively controlled due to rapid response. In the last year, there were about only 36 native cases and 246 imported cases. Yantai and Rizhao were the only cities in the province with COVID-19 outbreaks. It's because the residents who were infected outside our province and returned and became ill and infected their family members and other close contacts, resulting in these outbreaks. This year, there were 5,720 native cases and 426 imported cases. The epidemic in this year were mainly concentrated in March to April, with cases reported in 60 cities in the province. However, since mid to late May, no new native cases have been reported every day. This slide shows in this year the native cases in Shandong province were distributed all the cities, including Dongying, is the last city reported. This report is here. Reported. And the COVID-19 cases are mainly distributed in Qingdao, Weihai, Jinan, and Binzhou. The imported cases were mainly distributed in Qingdao, Jinan, and Weihai. In this slide shows this year the native cases were first reported in Qingdao, followed by local cases in Weihai, Binzhou, and Jinan. In Qingdao, Weihai, and Binzhou, the native transmission lasted less than one month. For Jinan, although the native transmission lasted more than 1 month, the daily new cases during transmission kept in a low level, about less than 50 cases in each day. Next, I will focus on the policies and measures in Shandong province in response to the COVID-19. Creative use of the classic 3 principles of infectious disease control and prevention, and the 4 is in infectious disease prevention and control are still applicable. The immediate implication of nucleic acid test is a key measure to take the next step. And those infected with positive nucleic acid test must report directly online as soon as possible. This measure facilitates timely action by other working shops, and those infected must be isolated and treated. At the same time, their close contacts should be quarantined. This slide shows how to balance the economic development and epidemic prevention and control has become a hot topic. In one word, in order to effectively control the COVID-19 epidemic without delaying economic development, I think the most important measure is strong government leadership. It's the key to the success of COVID-19 prevention and control. In our province, the leading group of prevention and control was headed by Secretary of the Communist Party of China, Shandong Province Committee, and the Governor of Shandong Province. According to the different characters of the epidemic at different times, the prevention and control protocols should be adjusted in a timely manner. In order to promptly respond to the epidemic, there are many measures such as hospital report cases online in 2 hours, labs positive report in 6 hours, CDC complete epidemiological investigations and followed up close contacts in 24 hours. The direct close contacts like eating, living, and working together should be isolated in only 8 hours. A very difficult work. And the other close contacts should be isolated in 48 hours. In the following up of infected persons, we define close contacts as any person who had contact within 1 meter with a confirmed or suspected case without effective protection since the date of illness and 4 days before illness onset. Symptomatic infections contacts is any person who had contacts within 1 meter with an asymptomatic infection in 5 days before sampling. Big data was applied to indicate population mobility for epidemiological studies and close contact tracing in Shandong province during epidemiological surveys. Extensive use of traditional Chinese medicine. The traditional Chinese medicine were also widely used in the 2009 year H1N1 flu response. This slide shows after the Chinese government introduced a policy to vaccinate all people for free against COVID-19. Shandong province responded positively in the process of COVID-19 vaccination, and a total of 93.6 million people were vaccinated in Shandong province as of April 30 this year. And 91.9 million people have completed 2 doses of vaccination. And 61 million people completed the 3rd vaccination. At the end of April this year, mobile cabin for isolation is about this slide shows the mobile cabin for isolation. No, this slide, I forgot something. Yes. Since the new Omicron strain is transmitted by droplet and contacts, to prevent further transmission of the new Omicron strain among the population, we have taken active and effective measures by stepping up 4,338 mobile cabin with 531,000 isolation rooms, setting up 280 designated hospitals, and the maximum number of patients that can be cured at the same time by those mentioned above, hospital is 72.8 thousand. In the course of COVID-19, Shandong province has set up a large nucleic acid testing team and epidemiological investigation team. And as the end of April this year, the maximum daily nucleic acid testing volume is 130 million. More than 9,000 epidemiological investigation teams have been set up, containing more than 50,000 people. To prevent COVID-19 input, people or goods from other countries or districts. People who come from other countries or districts will be taken 14 days quarantine at the designated sites, followed by 7 days health surveillance at home from the data entry. To prevent COVID-19 input, people or goods from other countries or districts, shipments with crude chain, the direct transfer to the centralized supervision special warehouse tested for SARS-CoV-2 and disinfected. Goods without crude chain transported directly transferred to the centralized supervision special warehouse tested for SARS-CoV-2 and detained and stayed for about 10 days. To prevent COVID-19 input people from other provinces, all people returning to Shandong from the other provinces should hold a nucleic acid test negative certificate within 48 hours, and a nucleic acid test should be conducted on the first and the third day after arrival. Another is strictly restricted the entry and return of people from counties, cities, or districts in high-risk areas. And a 7-day centralized quarantine followed by a 7-day health monitoring at home should be conducted for these peoples after arrival. To those people from the other province, persons in counties, cities, or districts in medium risk areas shall not return to Shandong unless necessary. And 7-day health monitoring at home should be conducted for them after arrival. The area that have not yet been announced as high or medium risk, but have a large number of newly infected cases and are at risk of community transmission, shall be subjected to county of the medium risk area. To prevent COVID-19 spreading silently in Shandong, people in Shandong before May people in 36 kinds of high-risk occupations should take 1 to 4 times of nucleic acid test in 14 days. It's free, always free. Since May, everyone in Shandong should take at least once nucleic acid test per week, and all the nucleic acid test for SARS-CoV-2 is free. This is a Shandong logo. In the right is a mountain tail. The bottom is Yellow River. Is our motherland river. These people I will all know is Confucius. His hometown is our hometown. Thanks.
You can unmute, Professor Wang.
你没有开。
Okay, thanks for Professor Ko's presentation. And I suppose many of you may have questions or insights talking with Professor Ko. However, he's not here, so please free to contact him if you are in any need. I suppose Professor Zhou may have the contact of Professor Ko, right? Okay. Now, here is our second speaker, the Professor Haitao Niu. He is a distinguished clinician and scientist majored in urology. Meanwhile, he is a hospital manager as deputy president of affiliated hospital of Qingdao University. The double identity allows him to practice new technologies. There are several photos. Do you have the photos, Dr. Zhou?
Yes, I can share.
Okay.
Yeah.
Okay. I suppose Dr. Zhou will show you some pictures. Then Professor Niu performed some remote surgery, and that is a picture.
Okay, just a moment. So Professor Wang, so will Professor Niu speak, or should I play his video?
Okay, that's okay. Okay, so I suppose he have done so many things to promote use of 5G mobile technologies in remote surgery, and I suppose in the presentation, Professor Niu will talk about his insight and experience with use of the new technology. I suppose his experience may have significant meaning in expanding the application of the new technology. Please enjoy the presentation.
Okay. So I suppose I should play the video. I did see Dr. Niu is here, but he may not be available to speak. So I will play the video now. Thank you.
Ladies and gentlemen, dear colleagues, good morning. I am Dr. Niu from the affiliated hospital of Qingdao University, China. It's my great honor to share my topic, robot-assisted laparoscopic urological telesurgery in China. At present, telemedicine has become an inevitable trend in the development of modern medical technology. Remote consultation, remote diagnosis, mobile wards, remote patient imaging sharing, and remote teaching and training has undergone considerable progress, but the progress in telesurgery is limited. The unbalanced distribution of medical resources in China is prominent, especially in remote and undeveloped areas. Telesurgery has the advantage of saving and optimizing medical resources, providing high-quality medical service for resource-poor areas. Telesurgery also can be used in special emergency situations, such as disaster area, epidemic, battlefield, and even space. Considering these conditions, during the past several years, some other Chinese doctors was tried to perform remote surgery. But these operations were only limited to a single case and do not require uninterrupted real-time surgical video transmission. Meanwhile, these surgeons do not place high demand on network latency and internet speed. In order to carry out the real telesurgery, our team first carried out the preparation of the telesurgery, including a number of animal experiments. We chose the Mako Robot as our assistant. In June 2019, a remote robot assisted laparoscopic animal nephrectomy was successfully performed by using the Mako hands. The operator, namely me, located in Qingdao, and the experimental pig located in Weihai with a distance of 300 kilometers. Next step, more animal research was finished even with a 3,000 kilometers distance. In order to help doctors adapting time delay, we designed several simulation tests. In the test, the delay of master sliver operation was artificially increased to 300 milliseconds to simulate the delay in remote control. After the epidemic outbreak in Wuhan at the end of 2019, I led more than 100 medical staff of our hospital to support Wuhan. During the period in Wuhan, our team further thought about the telemedicine. During the epidemic, medical resources were tight and the risk of infection was high. Telesurgery may break the barriers of time and distance, which was conducive to the scientific and reasonable redistribution of medical resources. Meanwhile, we had a deep understanding of the uneven distribution of our country's medical resources. Set the data of Shandong province as example. As this table shows, almost all the nephrectomy was done in top hospital. Well, most of these patients were not local residents, so the time and the money cost of patients were very high, and the burden of medical insurance was increased. In order to offer a better way to solve this problem, we decided to start the real telesurgery exploration to save patients. Before that, we passed the medical ethics approval in accordance with the requirement of clinical trial. The Surgeon Council was in Qingdao, and the Civil Council was in several county hospitals. The most far hospital is Xixiu District People's Hospital. The distance between the two places is nearly 3,000 kilometers. On September 24, 2020, we performed our first telesurgery. A patient from Xixiu District, Guizhou Province, suffered from blood cancer and needed cystectomy. The local doctor cannot do this kind of complicated operation. So we performed radical resection operation by telesurgery. The operation time of resected blood was about 2 hours. The blood loss was about 200 millimeters, and there were no intraoperative complications. We designed a two-night working scheme to ensure the operation runs smoothly. Plan A, both sides, Master and the Civil Council, were connected by 5G. Plan B, both sides were connected by the wired internet. Plan A was our first choice. We took Plan B as an alternative plan in case something wrong in 5G. The mean latence time of Plan A was 254 milliseconds. During the round trip, transporting delay was 104 milliseconds, and the data packet loss of both plans was 0. The patient recovered well after the operation and have returned to normal life. Many media, including CCTV and Shandong TV, reported our operation. In March 2020, Ministry of Industry and Information Technology of China, together with the Chinese Health Commission, made a policy development to give full play to the characteristic and advantage of 5G technology, and carried out 8 key directions, including remote treatment. In this context, after the COVID-19 epidemic in China was gradually effectively controlled, we start large sample clinical trial of telesurgery. We made a series of improvement to the networking plan this time, including triple safeguard and intraoperative monitoring and robot security control, and etc. Triple guarantee, including the first plan was all data transported by 5G. The second plan was the control signal was transported by 5G, and the video data was transported by via the internet. The third plan was all data is transported by via the internet. We used the self-developed software to monitor the network condition. It could provide time delay reports. The telesurgery robot was also fully secured through a variety of mechanical engineering methods. This map is Shandong. Our survey has covered about 10 county hospitals, and the Shuplo line means our hand has stretched beyond the Shandong province and reached Guizhou and Gansu province. Up to now, our team has finished 50 cases of operation, including 29 cases of radical nephrectomy, 3 cases of remote non-functional kidney, 17 cases of adrenal tumor resection, and 1 case of radical cystectomy. All the patient is well now. Here are some operating scenes of our remote surgery. Here is my gesture to control liver arm. Here represents some typical case of liver operation of radical nephrectomy. All these procedures was done by myself, and the speed is normally, and the average time delay is about 180 milliseconds, and this time delay is completely acceptable. The maximum diameter of the real tumor was 11 centimeters, which proved that our technology is mature, safe, and effective. In addition, we designed a series of self-measurement skills to evaluate the pre-operative anxiety of surgical personnel and patients. We also made a statistical analysis of the operative condition after the surgery. All these surveys show acceptance of the telesurgery gradually increased, both in doctor and in patient. Further analysis shows the telesurgery distance was significantly and positively correlated with the surgery operation time and intraoperative bleeding. In addition, members of the COA use committee were surveyed to assess per-acceptance of telesurgery. The results showed that most of them have a positive opinion about telesurgery. They also raised many useful suggestions, including improve the safety of software and hardware, keep improving equipment. All these suggestions was very helpful for our further work. Our project has received the attention of the government in China and have been used for paid assistance project of government. International academic organizations such as Clinic Robotic Surgery Association also invited us to give keynote speech. Based on our seasons of practice, we are deeply aware that telesurgery can optimize the current medical resource of China. Through the continuous telesurgery practice, we provided a new plan for great diagnosis and target medical assistance for poverty areas in China. Telesurgery is a new milestone. In the next step, our team will continuously optimize the equipment and the surgical process. At the same time, we will continue to reduce the time delay, improve the safety, and advocate the establishment of industry standard for telesurgery. In the future, we will strengthen the exchange and cooperation with international counterparts and jointly promote the rapid development of telesurgery. Thanks. Thank you all.
Thanks for the presentation and thanks for the listening. I believe you may have some comments, although the two speakers are not here, but I definitely write down your comments and talk with the two speakers. Do you have any comments? Okay, thanks for the listening. And I believe Dr. Zhou will show us some pictures about Professor Niu. In that?
And there is another one.
Okay.
Professor Wang, I think, can I give you some feedbacks if you don't mind?
Yes, of course.
Yeah, I've been to Shandong, many different cities. It's quite great to listen to the presentations from two professors. I'm very impressed by the centralized COVID-related management system and also the high technology of the telesurgery. Yeah, very much impressed. And thanks a lot for the cross-country sharing with us. As a Chinese in New Zealand, I'm very proud of the achievement. Thank you very much.
Thank you, and hope to meet you in Shandong province.
Thank you, and thanks to Dr. Zhou's arrangement. It's really impressive, and I learned a lot from the two presentations. Thank you very much.
Okay. So I believe you. Okay. I believe it must be a long listening. So how about we give a break, Dr. Zhou? Okay. Thank you. Thank you for listening. I enjoyed the presentation and communicate with all you guys. See you. Bye.
Thanks very much, Professor Wang, and that's excellent facilitation. And also thank you, Gloria, for your comments. And that's all very positive. And I also saw the comments from Ramil, and he said very impressive. So that's all great. So I think, can I just propose to have a short break, and we can start at 3:30. So we have roughly 14 minutes for the break. Thank you very much. So we will be here soon. Thank you.
to the last session of our second health forum, international collaboration with Asian countries. As Dr. Li Feng, Grace, Ramel, and Michelle, and several other speakers clarified earlier today, according to our priority of health reform in New Zealand, data and digitalization is one important part as enablers. So in this session, 3 Chinese experts will share their experience and achievements on big data and health innovation for health digitalization. Each speaker will have 30 minutes, including Q&A. Please feel free to raise questions using the Q&A function of Zoom. So first, I will introduce and invite Professor Gao to give us a presentation. Professor Gao is a professor of Shandong University. He is the former vice president of Qilu Hospital of Shandong University, director of Shandong Key Laboratory of Cardiovascular Proteomics, and vice chairman of Non-Invasive Cardiac Function Research Association of China. He's also the president of Shandong Healthcare Association. So welcome.
Maggie, you're on mute. So Maggie, can I just clarify with you, should I play the video or shall Professor Gao talk?
Please.
Okay, cool. I will do that now. Yep.
Ladies and gentlemen, good afternoon. I am Gao Haiqing from Qilu Hospital of Shandong University from China. Today, I will report the project of ECG remote monitoring technology and clinical research. My introduction is divided into 4 parts. The first one is the background of remote ECG project. In China, cardiovascular and cerebrovascular disease is one of the important diseases that threaten the health of Chinese people. Its mobility and mortality are more than 50% of the mobility of the old disease in our country. However, in addition to the death of various diseases, it was space life, that is, heart attack. The number of these deaths has reached 600,000, and most of these deaths occurred outside hospital, not in the hospital. There is another character of the incidence of the cardiovascular disease in China, that is, the incidence rate, the rural eyes, is still high, and the mobility in rural eyes has been close to or higher than that in urban eyes. Now, ECG examination is the basis and effective measure in the diagnostic and treatment of the cardiovascular disease. For emergency, ECG examination is very important, but ECG doesn't play a good role in process of alarm of cardiovascular emergency events. So why doesn't it work well? That what are the diagnostic stage? 这个你老念不对，这个你都给我去掉，我这个重念的。What are the disadvantages? Because usually most of ECGs we use in clinic are two kinds. The first one is the stated ECG, which have a short examination time and are limited by some activity. The another one, the traditional ambulatory ECG, can continuously record the ECG data, but it can't achieve the real-time monitoring and alarm in the critical moment. And the most of them are large. Then the lagging response is also a problem that we are feeling now. So far, all us now the occurrence of the emergence is urgent. There will be almost 1 per minute sudden cardiac death in China. Then 80% of sudden cardiac death outside in hospital. It carries by MI. But our traditional ablation ECG is only a retrospective diagnostic, which cannot play an alarm role from emergency. Addition to, due to some subjective reason, for example, the number of the professional ECG judgment technologists is too small, and the distribution is uneven. Medical institutions at the level have a different standard and interpreting ECG and another level of ECG technologists, and the most of high quality the persons are the mostly concentrated in the top the medical institution or hospital. Due to the lack of the technology, our grassroots, the medical institution, has hardly carried out this work, especially the hospital at the township level. In order to solve this problem, we use the wide application of the internet to try to solve the extension problem, the both connect patient with hospital and provide high quality service to patients in different regions and hospitals. The first is the current diagnostic and AR to help medical treatment. The second, the ECG monitoring device that can achieve real-time monitoring and alarming to play the role of the arm from the first outside the hospital. Third, we can empower the numbers of technologists by joining the third-party service. In other words, our patients and our hospitals can achieve the sector through the internet platform and redirect to the grassroots level and the place where there is the lack of medicine through the internet the platform. The second part is Rotor Ecg Monitoring Center. We consider the history from this picture that we remote Ecg Monitoring Center has been built since the 24 and available in the market in the 25. Up to now, we have gone through nearly the 20 years. This is fun of the establishment of our center on the jeweled factor, the center file. At that time, it was the first remote ECG monitoring center in China. Now, our remote monitoring center serves a wide region of people. The first is that our inpatient or outpatient to wear. The second is that the patients who are in the cooperation, the medical institution with our center need to wear. The third is the will of the family and our special service groups. Our center is composed of the two teams. The one of is the expert team, and the other is a technological service team. In addition, our service model in the 24 hours for full days. This picture shows that our workload is based on the daily online use, daily long-range analysis, daily real-time monitoring, the segment and avenues, the monitoring care. The third part is the technology achievement. Our projector has 4 self-developed technology. The first is the departure analysis and alarm systems. The second is the diversified interaction mode system. The third is long-range monitoring technology. The fourth is data record technology, has a black box in airplane. And the last one is most important. When there are some medical disputes, the medical failures, and other unpredictable problems in medical treatment, we can distinguish through the technology we can interpret some technology data in record, provide us with complete information, and help me analysis and solve problem. There are 9 patterns we obtained, including Chinese patents, Korea patents, Australia patents, American patents, and Taiwan patent. Our project has received government support. The include major the National Science and Technology Project, CARE project of clinics hospital, discovery, construction of Ministry of Health, CARE project of the international cooperation of Ministry of Science and Technology, and some project support in the Shandong province with a total amount of near 20 million yuan. These are achievement and the reward of our project. The first reward of Shandong Technology Invitation, and the second reward of Shandong Scientific and Technological Progress. There are 16 sectors in the Shandong covered by the technology. It forms the provision to city, to county, to township, to family, the mountain live, the cardiovascular acute event, provision and monitoring network. This model is created by our team, the firstly in China. The model is populated and used in the 50% of the domestic the hospital. He is list of someone. This is our service person. We can see from this person that when a patient outside or in hospital wear the device at any time, when he has a cardiovascular imaging, it will single will be automatically transmitted to our service center through 4G the website. After carefully the interpretation, our center will timely the feedback the clinical significant changes to the patient or his doctor, whether he needs to go to the nearest hospital for treatment immediately or not. The fourth part is clinical research. Now, this system has been widely used in various clinical disciplines. From this figure, we can know that in outpatient neurologic, cardiologic, geriatric department, it is most so used, accounting for more than the 75%. Of course, other departments are also gradually applied. This is the population we are concerned about. There are nine states of mode application in clinic. This is one of our clinical cases. This case is the 57-year-old female who came to the hospital for having 3 days because of stomach ache and nausea, considering whether he had cardiac disease or not. The doctor devised him to wear the ECG device. Then it found that there was ST segment, the traumatic event, and acute traumatic event. We considered that it was an AMT, and then immediately arranged to be hospitalized for the angiography. It was indicated has MVA disease, where black definitely. The stent was unstable, which severed the patient's life. This is a patient with VF. This patient is low because we timely captured the information of visit phenotype. B is a hospital. We informed his doctor in time. He was carried out active recall and came to life finally. The following is a sample the video. You can see from this video that this is which could addressed. The ECG has approved the strength line. He is a patient with cardiac arrest. Throughout real-time monitoring, we found his carried cardiac arrest and then notified his doctor for timely recall, and the patient was saved. Wen Jiabao, the ex-premier of our country, visited project and the Cardiac team. Director of National Health Commission, Li Bing, came to our center for inspection. There are some families expecting to come to our center to inspect. This is more than 20 major specially organized by the publicated the Department of the National Health Commission. We came to our center for news, intervention, and conferences. Well, this is the old introduction of our projector. Thank you, everyone. 也是那么多话。
Thanks, Professor Gao and your team. So I collected some feedbacks, and also there's a question from online. Mentioned right now, the devices can't be officially used by medical service provider in countries like New Zealand. Does Professor Gao have any recommendations on how those devices used in countries like New Zealand? That's one question from our online attendees. And Gloria comments, thank you, Professor Gao, for sharing. Very impressive. Thank you, Gloria. Yeah.
Thank you.
Professor Gao, can you turn? Yeah. Okay. Thank you.
我该说了。好。好，没有了，我就跟他说这个就行。好。
Yeah, while Professor Gao is working, read comments from the online attendees. Thank you, Professor Gao. Your experience on the designing, development, and implementation of a cardiac remote monitoring center with multiple disciplinary experts to support the healthcare organizations in towns and serving the populations in remote areas has set up a good example for us. Thank you for the comment. Yep.
Okay. We are looking forward to the developing collaboration with team to contribute to the communities and the people in New Zealand. Actually, we do have a device in New Zealand and it works very well. Thank you.
Thank you.
Okay. Next.
So according to the Sure. Thank you. Thank you, Professor Gao. So we will move on to the next speaker according to our time setting and schedule. Thanks, Professor Gao and your team. Next speaker is Professor Xu Fuzheng from Shandong, the National Institute of Health Data Science of China. Professor Xu is the Dean and President of the National Institute of Health Data Science of China.
Yeah.
And his main research interests are health big data theory and methodology, causal inference of health big data, etc. He has presided over 10 national level grants, such as the National Key Research and Development Program of China, international cooperation projects of national natural science. He has published more than 150 science papers. Professor Xu, please.
Hi. Many thanks for giving opportunity to communication. Today, my topic is digital health, a part of the public health practice. I will focus on the four parts. The first, I will introduce digital health capture and technology briefly. You know, health has four revolutions. The one is public health, second, clinical diagnostic, and third is information technology. Today is smart medical. So CARE4 is a digital health management model corresponding to the health. Health4 is developed based on the industrial health. So CARE4 may change the way providing healthcare service. Focus on the trusted and integrated networks, organizations, people, and technology. These networks are tools will help people co-manage or self-manage. It will make personalized service more responsive, effective, and substantial. Another in public health also have four revolution. One is the preventive health service, and the two is public health service, and the third is the community service. And today have developed into digital health service. So digital public health is the new public health and medical technology system for enrich public health system and carry out public health monitor, forecasting, and early warning, and precise intervention practice by applying digital health technique. This including the 5G and the Internet of Things, wireless sensor, intelligence medicine, mobile health, digital twin, digital phenotype, and biomics and others is the background of internet, big data, and artificial. So digital health technique could promote prevention, case service, public service, and community service, and a new stage of smart. Several techniques have been used widely. The first is the things of the Internet of Things. This combines sensor, communicator, intelligence. For example, it is used in smart city. The second is by sensors. By sensors is an analysis of device that converted biological research into electro signals. Also, we familiar the smartphone. Use the smartphone, we can conduct health management. For example, this is use the big data to use the COPD care. Also, we familiar to use the artificial intelligence. We are interested in intelligence world. All things sensor, all things connected, and all things intelligence. For example, this is using the AI technique to measurement or to permit diabetes. Another maybe is the digital twin. A digital twin is create a digital column of human system. This digital column is created based on the information platform is virtual. So this the digital twin also used to personalize medicine. Another concept maybe is digital phenotyping. Digital phenotyping is a novel biomarker obtained by pattern recognition and feature extraction from raw features using machine learning to get the digital biomarkers and to summarize to digital phenotyping. For example, we using the digital phenotype can get the phenotype from the feature image, And another is mobile health. So mobile health maybe is to develop and utilize digital technique to proper health graph and carry out relevant practice, including the application of digital techniques. So second, I will introduce our developing digital technique. First, the digital technique empowers COVID-19 prevention and control. So first is we developed the symbolized emerging decision support system for prevention and control imported effect disease. You can show the video.
This is the system we developed for the simulation, analysis, and prediction of the epidemic. There are 4 modules in total. The home page is module 1, epidemic simulation page. This page shows the epidemic simulation in different cities in China in the context of the outbreak we cite. When the mouse is over, city infection data for that city will appear. Throughout the map, the initial outbreak city is clearly marked. The list on the right shows the top 10 cities with the most infections nationwide. In the upper left corner of the page, You can choose to display the infection situation in the form of a heat map or a punctuation map. Here, in the upper right corner, you can set the background of situation, including the outbreak city, the initial transmission capacity of the virus, the observation period. After setting, you can click Output to display the results. You can click a point on the timeline to fast forward to the date you want to observe. You can also click the Play button to automatically play. The top 10 cities on the right with the most infections will be marked with the colored labels on the map, and the colors are in one-to-one correspondence. The map also has a zoom function, so you don't have to worry about being too crowded from city to city to see the specific infection situation for one city. Then we can see Module 2, virus transmission module.
So the second technique is smart toolkit for field epidemiology investigation of COVID-19. Please follow up
这是我们开发的流调工具包，是在校园环境或其他有大数据支持的环境下，用来提高疫情流调追踪精度及速度的 APP。同时，本 APP 会为流调人员提供电子化平台，提高流调工作效率。在登录页面，输入流调人员自己的用户名、密码，点击登录即可登录到系统主页面。有4个功能，分别是身份快速识别、流调信息录入、任务清单和流调图谱。在真实使用场景，点击快速身份识别、健康码扫码，长按 Pad 上的黄色键进行快速扫码，然后选择功能，点击进行流调按钮，直接进入流调信息录入。系统会通过校内网快速拉取人员信息，自动填写基本信息，确认无误后，进入流调轨迹标签页，点击打开轨迹列表，就可进行轨迹录入。系统也会自动通过大数据获取一部分轨迹信息，由人工补充其他的轨迹。录入完成后，点击保存并返回，流调轨迹页面会自动生成流调报告。在密接人员列表里，也会出现大数据检索到的和手动录入的人员列表、密接地点列表，然后完善14天其他接触信息，流调完成。如果疫情流调人员需要快速查询某人员这段时间都接触过哪些人，长时间逗留过哪些地点，通过相似的流程，点击快速身份识别，识别健康码，扫码，点击查看图谱，就可以通过数据后台查看此人近7天的接触图谱。如有需要，可进一步对接触者进行流调任务登记。
So we also developed the preventive surveillance of COVID in community and capture. Please share this video.
Real-time monitoring system. We enter the campus personnel activity knowledge graph interface. Enter the name and ID number of the campus person you want to inquire about, and the starting time and the ending time. Click Inquire. The person and the people who appeared at the same time and place will be displayed, in which the circle representing the person is deep blue, and circles representing people who appear together is the light blue. The scope of the query includes instantaneous contact, such as the punch-in records of the campus card, short-term contact, such as class records, and long-time contact, such as residential address. We right-click on any people to display the menu interface. Click Personnel Details to display the detailed information of the person. Click Switch Node to inquire the co-occurrence node of the person. Then we click Join Task to add the person to the academic investigation list for further academic investigation work. By searching based on knowledge graph, we can quickly locate people who have appeared with the target people and then speed up the epidemiological investigation process.
So we also developed a real-time surveillance system of COVID-19 epidemic, dynamic, and control prevention. We use the SRS model and deep learning to develop the model. And we developed the system, it provides a virtual platform for WHO and the government to capture the epidemic spread and optimize the prevention and control policy and measures. For example, this is the real-time surveillance epidemic industry, and this is the real-time monitor of epidemic dynamics. We also real-time displays the result and spread. Another maybe is the real-time surveillance of epidemic process measured by case, or the real-time prediction of mortality. This is also used. And another is real-time surveillance of epidemic process measured by death tolls. Also, we can real-time prediction of mortality. This is the process of mortality in the whole world. Another use is digital healthy powers chronic disease manager. In China, hypertension is a major public problem in China population. So our study showed that the medication adherence is a key factor to improve the blood pressure. For example, this is low adherence and high adherence. And also, we find a causal relationship between the adherence and the CVD mortality has still documented. So based on this result, we developing dental health technique for hypertension intervention. In China, rural doctors have low professional skill to master complete hypertension prevention and treatment guidelines. So using ALT and the decision-making tree model, we transform the complete evidence-based technique to knowledge graph. By doing this, raw doctors can easily and correctly diagnose and treat hypertension patients. This is a tree program. We also developed the digital technique. And we developing the active line colline the intelligence management system. Please follow following the English subtitles.
以智慧主动健康头脑引擎为中枢神经系统，有机整合十大慢变一体化因果推理知识图谱，智能在线预测预警体系，实时智能主动个性化干预体系等技术，提供动态标准规范可用的健康档案，在线智能预测预警，实时主动健康个性化干预，以及内容详实的健康管理报告，多维可翻的统计图表等服务，并通过多种技术手段确保数据安全。目前，系统已在5个县区示范推广应用，其中巨野县覆盖人群112851人，寿光市覆盖人群117075人，围城区覆盖人群34524人，方子区覆盖人群35050人，昌乐县覆盖人群71987人，肥城市覆盖人群112445人，共计483932人。系统的示范应用为基层公卫医师进一步做好基层卫生健康管理工作提供了重要的科学依据和信息化手段，将居民看不懂的体检数据转变为可视化的健康风险，为居民提供了清晰直观、简单易懂的个性化健康风险评估报告，让居民能够充分认识自己的健康问题，改善不良生活方式，明确并控制风险因素，学会自我主动的健康管理，提升了健康体检数据的利用价值。通过健康状况分析，卫生健康主管部门可全面掌握辖区内居民患病情况、风险分布情况、主要危险因素、不良生活方式等，为合理规划卫生健康资源、提高健康管理水平提供了决策参考。
And finally, We also developed smarter acting systems. Please follow up the English subtitle.
智慧餐饮解决方案。神思电子积极响应健康中国2030规划纲要、国民营养计划2017至2030，并贯彻落实习近平总书记对制止餐饮浪费行为的重要指示，与餐股企业效联科技协同创新，融合人工智能、物联网、大数据、云计算等新一代信息技术，构建餐饮健康大脑，聚力推出智慧餐饮解决方案。同时，神思电子联合北京大学、山东大学共同承担科技部主动健康和老龄化科技应对重点研发计划，致力打造智慧餐饮加健康管理全新方案。智慧餐饮涵盖自助模式、自选模式、特色模式、订餐模式、定额模式，满足各类餐厅场景。其中，自助模式即可在现有的备餐台基础上进行升级，利用智能备餐一体机替换现有设备，实现数小时内的快速部署。也可对新建或改造餐厅整体进行定制化设计与升级，实现按需取餐、精准计量、无感支付的健康智慧餐饮新模式。智慧餐饮系统通过按需取餐、按需购采，可将餐厅的采购成本降低10%以上，厨余垃圾减少40%以上。另外，利用智能视频监控技术，实现后厨工作人员行为分析，对未按规定穿厨师服、戴厨师帽、戴口罩等行为进行监控与告警，保障后厨工作人员行为规范。健康管理包含营养分析与健康干预，系统内置上百种食物的营养数据，结合精准计量技术，可以准确分析用户各类营养元素摄入量。同时，神思电子与投资的健康管理服务商组成健康管理生态，用户可使用智能穿戴设备采集睡眠数据、体征数据、运动数据等，打通数据步道，全面指导用户合理膳食、科学运动，实现健康干预，打造专属个人健康专家。神思电子智慧餐饮加健康管理解决方案已在政府、银行、企业、高校等场景全面落地应用。未来，神思电子将充分运用新一代信息技术，持续提升智慧餐饮加健康管理创新及服务水平，为落实健康中国发展战略做出积极贡献。
好， that's all. Thank you, Dr. Ma.
Thank you very much, Professor Xue. We still remember the informative presentation you delivered in our first International Health Forum in 2019. And according to today's your sharing, today's we can recognize that how big and rapid progress and development your team and great teamwork has done. It's very impressive. We have, according to the online question, we have two now. I'll read out and you can answer one by one. First one is, according to your expertise, would you please highlight your main experience on how to use healthcare big data in China to support the development of digital health technologies? This is the first one. Second one.
Oh, thank you, Dr. Ma. This is a good question. So in China, we have established a big data, national big data center in North China. It's located in Shandong province, Jinan. So we developed many techniques and big data platforms to support the digital technology development. Maybe I can show a brief video for to use. Thank you.
And I will quickly read out.
Follow up the English subtitle because it's time-telling. I cannot translate it.
Generated uneven quality and inconsistent standards. However, it's derived from realistic clinical scenarios and reflects the real situation of patients, and the sample size and data volume are huge. Therefore, its value is extremely high. Medical science standard data and strict design and quality control are an important source. However, it often deviates from the real clinical world, and the sample size and data volume are small. Therefore, only by transforming big data into medical science big data can evidence-based research be supported. However, in the complex process of data collection, integration, correlation, optimization, mining, analysis, transformation, and application, there are many pinpoints and difficulties, which make it difficult for data to be transformed into evidence, large-scale application, and finally become a bottleneck. First, the lack of a standard system of whole process for data governance makes it difficult to transform big data into scientific big data. For multi-source, heterogeneous and isolated data sources to realize the automated construction of data results standard library. A standard system of data integration, RCDM, and an intelligent tool are developed. A standard system of big data queue, CCDM, and an intelligent tool have been developed, and the establishment of medical science queue big data warehouse has been realized. Based on the evidence-based medical knowledge source, a standard system of evidence-based causal graph, GCDM, and a database engineer of medical brain are developed. In short, in view of the lack of pinpoints of standard system of the whole flow of data governance, created the data acquisition RCDM blends together the common data model, QCCDM common data model, and evidence-based GCDM map common data model, solves the bad data compliance, makes up the queue, the missing queue, builds the evidence-based map, open up the data governance parts. Secondly, the lack of full-stack intelligent tools, making it difficult to scale application. To this end, a healthcare big data integrated system is developed. Innovation Point 2 is formed, aiming at the data governance application. A full-stack engineering intelligent system of health and medical big data is developed to realize process-based analysis, solve the problem of insufficient data through integration, fill in the lack of design and analysis process, and lower the threshold for professional use, realize the full stack service of data. Thirdly, it's difficult to obtain evidence-based evidence from big data due to the lack of evidence-based causal inference, prediction, and decision-making method, which can only reflect correction, but it's difficult to prove causality. To this end, a method system of big data causal inference, prediction, and decision-making has been established, and the process of research, design, and analysis has been realized. Innovation Point 3 is formed. There is a lack of causal inference methods for data analysis. Therefore, a four-dimension causal inference, prediction, and decision method system and intelligent tool theory method model 2 is established, which breaks the bottleneck of big data causal inference, online prediction, and evidence theory, and realize causal inference in the whole evidence chain. Fourthly, the lack of multi-scene scale promotion model, resulting in difficult industrialization. To this end, China has developed a smart medicine system featuring one brain and multi-terminals, which has achieved large-scale application and industrial transformation. Aiming at the data transformation application, a multi-brain intelligent medical system has been developed, and the innovational technological services tools. The formation of a multi-brain technology promotion model. The One Brain Center uses the graph database, integrates the various standards, tools, and models, and provides ordering and personalized services on demand, which solves the problem that the traditional service model cannot realize. Multi-channel has changed the traditional mode of only exporting intellectual property rights, and formed a multi-scene, large-scale, and full-chain promotion characterized by the output of technical services. Finally, the full-stack technical process service of data collection, integration, collection, and optimization, mining and analysis, transformation, and application is realized. The centralized deployment relying on the one lake and three big data facilities of the North Center has realized the real-time integration and intensive application of data of more than 600 medical institutions and 70 million people in the province. By using blockchain, edge computing, and further learning technologies, a collaborative network of big data covering many provinces and cities has been established to achieve cross-domain.
Thank you. This is our platform technical system.
Thank you, Professor. Sure, I think, according to your supplement sharing, I think it's answer Dr. Li Fengzhou's question about how is the app or tools adopted by other provinces, as it is very efficient. Thank you very much, Professor Xu. Besides that, are there any kind of supplement opinions you would like to add to answer that question?
Okay. Thank you, Professor Xie.
Now, I think I would like to share opinion from Gloria Gao. I think it can represent our attendees' opinions and feedbacks. Thank you, Professor Xu, for sharing the powerful digital health technology that contributes to both epidemiological and chronological disease. The catering system is smart to holistically manage health, nutrition, hygiene, and waste management. Learned a lot from your presentation. Well said, Gloria. Yeah. Thank you. Because of the time limitation, we will move on to the next presentation. Thank you very much, Professor Xu and your team. We're looking forward for your next visit to New Zealand. Thank you. So our next presenter, who will be our last one for our whole Health Inform, we will introduce Dr. Chen Yunsu. Dr. Chen is the chief physician, MD, who is working in the Department of Joint Surgery of the 6 People's Hospital affiliated to Shanghai Jiao Tong University. Engaged in clinical and research work on joint surgery, he also further studied on the adult joint surgery in the Massachusetts General Hospital in the United States. He also visited joint research centers in Europe, Australia, Japan, South Korea, and other countries. Committed to basic and clinical research on hip and knee joint replacement and revision surgery, minimal invasive hip and knee joint replacement, hip joint surface replacement, and navigation or robot supported minimal invasive knee joint replacement. He has undertaken and completed 8 research projects. Welcome, Dr. Chen.
Good afternoon, ladies and gentlemen. Thanks for the introduction from Dr. Ma. It's my great honor to be here, invited by Mr. Zhou. So previously, the two speakers said that digital technology used in the great views, but as a surgeon of orthopedic, I just introduced some small piece, the technology, digital technology used in the orthopedic surgery. So I will introduce the use of Mako Robot in arthroplasty in Shanghai in our hospital. Here is our hospital in Shanghai, the number 6 people hospital. And we have more than 3,000 beds. And we are the one of the biggest joint center in the south of China. We finish about 5,000 arthroplasties, including hip and knee arthroplasties annually. With the development of the technology, most very difficult disease can be solved by arthroplasties, such as very severe bone disease, joint disease. We can replace it with hip and knee arthroplasties. And digital technology are used in our surgery very frequently, such as VR techniques, sensors, AR, and navigations. Sometimes we use robots. In the global market, the first-line orthopedic companies are all involved in the navigation and the robot, especially in the joint surgery replacement. Also, in China, the local market, we have more than 10 companies are making their own robot in the joint replacement. So the time of digital orthopedic is coming. And then we use Mako Robot in our hospitals. The Mako Robot is the most popular robot in the hip and knee joint replacement surgery. It is made by Stryker. It was approved by the FDA of the United States, used in the uni-knee arthroplasties, total hip arthroplasties, and total knee arthroplasty in 2006, 2010, and 2015. It is a CT image-based planning. So I will introduce robotic-assisted total hip and total knee arthroplasties separately. First, I will introduce robotic-assisted total hip arthroplasty. We know we do a lot of total hip arthroplasties, and the clinical results are good, but about 38% to 47% of acetabular implants are inserted outside the desired range. That may cause the dislocation of hip, the accelerated wear, and early loosening, and sometimes leg length discrepancy and pain may cause the suit. And the accurate implantation of acetabulum can be enhanced with the robotic arm assistant. It can raise the accuracy about 45%. So this is the Mako system. It has 3 core features: enhanced planning, dynamic joint plan balancing, and haptic guidance. So this is a workflow. So we first planning, put the landmark placement and put the pelvic area. Then we verify the checkpoint and acetabular registration. With the arm assistant, we can read the acetabulum and put the cut in, and then do the femoral preparation. We do the trial, and we can see the trial result on the screen. So pre-operative planning is we should do the CT scan and segmentation, and the subject, the specialist will do the CT markers. They can establish offset, leg length, and version. And also we can plan the implant size and position. So under planning, we can see the offset and leg length, can compare the disease hip versus opposite hip. We can also compare the planned hip with pre-operative plan. the acetabular shell planning, we can see the plan on the coronal view. We can see on the transverse view. Also, we can see from the reaming view. And also, we can plan the stem size and stem position on the coronal view and the transverse view. This is very important. Before the operation, we can do the reduction of implant. We can control the leg length and offset before the operation on the computer. Then we can compare the plan with pre-operative. We can compare the plan with opposite hip and make the right decision. So this is an example. It's a female 42 years old with a diagnosis of left hip dysplasia with secondary osteoarthritis. So pre-operative planning, we did do the 3D CT model. So we can see this is the pre-operative. So we plan the acetabulum with this is the sagittal and the transverse view. So this is the femoral stem planning. You can choose the right size, right position of the cutting. So, and what is the reduced implant planning? Is before the operation, we can see what will be if we put the cup and the stem in. This is also before the operation. We can see the X-ray. So this is the in the operating theater, we can position the patient and insert the array. Then checkpoint placement, then regular exposure with this hip dislocation, cut the femoral neck. Then we register acetabulum. Then after registration, we can introduce the robot arm to assist our reaming. So this is the ream. The robot arm can control the depth and the angle of the reaming. And also, if it is out of the range, it will stop. So we can see if the surgeon ream 2.3 millimeters beyond the cut plan, it will shut off. So this is very safe especially for the newcomer. So when we impact the cup in, we can also do it with the robot arm. It will control the inclination, the version, and the depth of the cup. So this is the view before the reaming. This is after reaming. Then we put the cup in, implanted, and it control the angle and control the depth. It is very safe. After cup in position, we can verify it if it is our desired angle and the depth. Then we reduce our hip and we can check the leg length. Is it equal or shall we adjust it? So this is the reduction assessment. We can control the leg length and offset. This is very important because offset can control the stability of our hip. That will cause the dislocation. So this is the post-op X-ray and intraoperative image. So the robot assists total hip arthroplasties may help surgeon to avoid dislocation, leg length discrepancy, and maybe it can help surgeon to avoid accelerated wear and cup loosening. That makes the surgery more safe and more accurate. And the clinical result of the robot assisted total hip is very good. So here are the very good outcomes compared to the traditional technique. We can also use this technology to do some very difficult case. For example, ankylosing of the hip. So these are very difficult cases. We can use the planning of the robot, and we can with the arm to do the cut, reaming, and position. And the clinical result will be much better compared to our traditional technique. And then I will just briefly introduce the robotic-assisted total knee arthroplasties. So why total knee need robotic assist? According to the literature, the total knee arthroplasties, the survivorship of 15 years are very great, more than 90%. But even with very good survivorship, about 20% of patients with total knee arthroplasties are dissatisfied. And the key driver for revision are malalignment and joint imbalancing, excluding the infection. So these are technical defect. It's very interesting. When we fly from Shanghai to Auckland, nobody will care about who is driving the plane. But when we have an operation, most patients will care about who will do the operation for me, who will be the surgeon, because the masters, the experienced surgeon, have good clinical results. They could make good surgery. So we need digital technology to transfer this experience, this master's experience, to precisely plan and implement it. Should be standard and personalized. So this is the digital technologies view. So goal of robotic assisted total knee, improve in precision of osteotomy, alignment, and soft tissue balancing. It can also improve the safety and the safety of the operation and improve the clinical result and the survivorship of the implants. So this is the Mako arthroplasty in the United States of 2019. It's very surprising. About 1/10 of the total joint replacement in the United States are done by robots, and 80% of them are total knee arthroplasties. So it is still increasing. In 2018, the first Mako robot total knee arthroplasty was done in our hospital in China. So we do the first case. The Mako armed robot total knee arthroplasty system includes 3 components. This is the Mako robotic arm. So this is camera scanner and the software. And the workflow of Mako total knee are very similar to the total hips. They include 4 parts: the plan with 3D CT based, and we can access primary soft tissue balance. Then we balance the knee with fine tuning of implant position according to the soft tissue balance. Last, we cut precisely and safely with haptic feedback. So this is pre-operative planning workflow. Also CT scan segmentation. When we do a knee, we should scan hip, knee, and ankle, 3 parts. And after that, we can do the plan. We can plan the size and the position of the knee implants. All these works are done now still by the human beings, not the AI. So you can see the plan. It is CT scan, and we segment it and reconstruct it to the complete bone. Then we can plan the size and the position of the implant. So this is before operation. In the real operating theater, we can access the dynamic balancing with individualized soft tissue condition. This is balancing. We can see this is flexion of 93 flexion. We can balance. The real part balancing is here. We can fine tuning the implant position according to the intraoperative extension and flexion soft tissue balance. That means if we fine tune the position of the implant, maybe we can avoid unnecessary soft tissue release. Then we can cause less pain. This is very important because total hip arthroplasty is a very painful surgery because we do a lot of soft tissue release. at last, with the robot arm, we can accurately do the bone cutting without any cutting jigs. With traditional technique, we should put some cutting jigs in, and then we do the cut. And this is a haptic bone preparation with very safe margin. If the saw is beyond the safe margin, it will stop. So it is very safe. We will not hurt the nerve, will not hurt the vessels, will not hurt the ligament. So it will be much accurate and much safer. So the advantage of robotic assisted total knee arthroplasties, it can be precise osteotomy with very good soft tissue protection, and it was precise and individualized implanting and minimize soft tissue release that can improve patients' pain and functions. Also, this is a very good teaching tool because with this robot, we can teach our fellows or teach our residents how to do a good total knee arthroplasties. Also, with the robot in the theater, we can minimize the need for tools and staffs. Usually we can do the arthroplasty of total knee arthroplasty only with one assistant with the robot arm. And without any cutting jigs prepared, so the tools are much lesser. And also it's very important because the cementless CR implants seems to be better, but with traditional technology, we cannot do the bone cutting so accurately and safely. So with the robot armed technology, we can make the CR implant cementally safe. And the clinical result of Mako total knee arthroplasty is also very good. So here's the literature report. See, the short-term results are very good, better than traditional technique. So these are the reports. But still, till now, the robot is still not perfect. It's far from perfect. Just like as the first generation mobile phone, not just like this one. Because the pre-operative planning is still not perfect. It's the anatomic reconstruction. Now we are doing kinematic alignment, we are doing functional alignment, but the gold standard is still not known. And the pre-operative planning is time-consuming because it's still by human beings. In the near future, I think it will be planned by the AI. And the intraoperative assessment is excessively depend on the experience of the surgeon. But in the near future, it will depend on the sensor that can be digitalized. And with great data collection, maybe it will be adjusted by the AI system. And very important, not all the patients are the same, but till now we still use the same implant for every patient, for different patient. But in the near future, with the robot assistant, I think we can individualize the implant for each patient. From May 2018 till now, in our institute, we have more than 500 robot-assisted total knee arthroplasty. Short-term clinical results are very good. Yes, the robot is not perfect yet, but I think it will be better. Thanks for your attention.
Thank you very much, Dr. Chen. It's a really impressive evidence-based presentation. We learned a lot. Thank you very much, especially that now our North Shore Hospital of Waitemata DHB developing a minimal invasive surgical center. And we're looking forward to further communicate with you and your team to see if in the future that our Asian International Collaboration of Waitemata DHB, leading by Dr. Li Feng, can set up more networks and further develop of our collaborations with our Asian and Chinese teams to go further. for the implementation and application of the new technologies to serve our populations here. Are there any are there any questions and comments? I read through comments from Dr. Li Feng. Excellent, Dr. Chen. We hope to look at this as a prototyped area for international collaboration. Thank you very much. And comments from Gloria. Thank you very much, Dr. Chen. It was a very detailed introduction of the robot assistance of digital technology to improve the safety and accuracy in orthopedic surgery, widely beneficial for the patients in need. Great job to bring Mako to clinical. Very impressive.
Thanks.
Yeah. To summarize for this session, I got a feedback from online reflected to the presentation of this session, 3 great presentations, as well as the last session by Professor Niu Haitao. Using telehealth and health innovations to reduce inequity in healthcare services to satisfy the needs of people living in remote areas and benefit all communities and ethnic populations. Well done, everyone. Thank you. So now I will hand over to Dr. Li Feng.
Thanks very much, Maggie, and that's excellent facilitation, and that's a wonderful job you have done. And thank you, Dr. Chen, for the wonderful presentation, and all the speakers today and yesterday. So I think, time flies. We have had 2 wonderful half days for this forum. I think I have learned a lot. And, there are something certainly I'm familiar with, but there is also something new, I have to learn. I may need to look at the video again and again, because there are a lot of good things inside. And certainly, I think from this forum, basically the forum aims to enhance the relationship, to be a platform for direct dialogue, networking, and engagement. And also, I think, to share expertise and experiences, between countries and also within countries. So I think this is a very good platform. But our collaboration will not stop here. So this is just a great milestone. So we still need to continue to work together and to look at opportunities coming from the networking, from the engagement, from sharing expertise. So moving forward, I think we do need to look at the new opportunities. And I think I would like to thank all the speakers. Yesterday we got speakers from Singapore and from New Zealand Ministry of Health, and certainly the experiences from Chinese CDC, and we've heard the addresses from Dr. Andrew Brandt, and also Mr. Lei Zhen, the Deputy Consul General of China in Auckland, and the Executive Director of New Zealand China Council. So also all these are wonderful, and we had a wonderful session talking about integrating Rogan practice with Western medicine, and the idea was about collaboration. So I think I picked that up, and that's quite important. And today we had a very important session on Asian health. Now I'm sure you have heard a lot of news this week. Even today, I think there are also media release about the health reform. So in New Zealand, we still need to work very, very hard to think about how we can improve Asian and ethnic population health, how we can work together, between government organizations, CDHBs, community organizations, and academics. So I think we do need to look at the new opportunities within the national health reform, whether we should have a policy at the national level, or should we have a regional plan, and what would be the structure, so covering all these areas from national level, regional level to district level. And I'm sure, we need to work together, continuously. Grace is here, and we got Gloria and other people. So I think this is a wonderful opportunity. So from this platform, from this forum, we will produce the e-handbook and then share with everyone. And we will also produce a communique or statement from this forum so that we can continue to have the conversations or discussions. So today is a great start. We need to move on. So thank you very much, all the speakers, facilitators, and our Komato Fraser. Thank you so much, Komato Fraser. So can I just pass the platform to you now?
Thank you. Thank you, Li Feng. What a wonderful kaupapa these last 2 days. And and of course, my congratulations and my thanks to those wonderful presenters and the kaupapa that they presented today. As we started the whole thing with the prayer, we will close with a prayer as well. And so just bear with me. Pardon me. Ite mutinga o tō mātou mahi te rānei, ko tātou tēnei tuku whakawhetau na ki a koe. Mō ngā manaki tanga katoa nāura I utane ki ngā tātou katoa. Mai te tīmatanga tēnei kaupapa I te rārāraka, taino atu ki tēnei wā. Just to translate, Lord, we give thanks for all the blessings that you bestowed upon us all in the last 2 days over this wonderful hui between our two countries, or the Asian countries, and our country of Aotearoa, New Zealand. Ko te kaupapa e kōrero hia nei rātou, e whana ki te hauora o te tangata, and we all know that what they've spoken about was the health and well-being of our people, of all countries. Ko te mātou inmei ki a koe, ke tia ki manaki, tia mai tātou katoa I roti ngā wā katoa, me o mātou whānau. Kia noho haumaru, kia noho ora katoa tātou I ngā wā katoa. We ask of you in prayer to look after each and every one of us and our families. If we are parents and grandparents, look after our children and our grandchildren. Keep us safe, keep us free of the COVID-19 that's still rampant out there. If it's possible to bring peace and harmony to our world, Lord, we ask of you to take care of each and every one of us. And until we meet again, God bless everyone, Lord. And so with that, we say thank you, and we say all these things in the name of the Father, the Son, and the Holy Spirit. Homie, hui tai ki. Kia ora. Thank you, Lai Feng.
Thanks so much. Thanks so much, Komato Fraser. That's great. Thank you so much. For the 2 days, it's wonderful. Thank you. Can I also thank all the people working behind the scenes, and certainly Maggie, working so hard, and all other people working behind the scenes, and our IT team here supporting us. Thank you so much. Bye-bye.
Thank you very much. And thank you, Grace, for your great support. Thank you, Leifa.
Thank you.
Okay.
Thank you.
So good rest.
Joe, thank you.
Thank you, Professor.
Thank you.
Thank you.
We just finished.